Let's just review very quickly some clinical research. We talked about Dr. Alls. Remember back in 1986, she had one of her very first articles that talked about the fact of the synaptive theory of growth and development and how the environment and the infant, impinged on one another and how they were integral in what was taking place. We also looked at Peter Gorski. Remember, he's the one that gave us our behavioral stress cues, and the fact that in 1990 he did a paper that talked about the handling effects of preterm infants in the hospital. We then have to take and we have to look at Dr. Alls again in 1986, because she really did give us an article that talked about the fact that when we have the appropriate environment for our infants, that we have fewer days on the respirator, we have fewer days on oxygen, and that we are exhibiting faster times to appropriate bottle feed, and that we have an infant that has much more organized behavior. So, we are progressing in the fact that we know that the environment does play a critical part in the outcomes of our infants. And then, of course, we have to take and we have to thank Dr. Jerry Merenstein in 1999 for his approach and his speech at the National Neonatal Development meeting that was held in Chicago. And that is the fact that NICUs that are choosing not to implement developmental care, that they should consider but doing a trial to try to disprove the fact that developmental care makes a difference. I think this was probably one of the most moving speeches and announcements that I had ever been involved with, because of the simple reason he truly challenged us to look at our practice and to embrace this theory of developmental care, and that if we were not embracing it, then we should prove why it was not an avenue that we should investigate further. And then, of course, we have Dr. Gordon Avery, and in an article that he wrote in, I believe, 1989, and that is the fact that the consensus is that the high-tech nursery that we know is not the appropriate environment for an immature, premature developing system. Having known that way back when, 1989, and of course, it took us to almost 2005 in order to really recreate and to bring some credence to the fact of changing the environment and really making tremendous strides in how we would change that NICU environment. And of course, we take and we look at the study done by Gibbons, Hoth, Coughlin, and Linda Frank, in the fact of that universal, the universe of developmental care, and the new conceptual model on how we apply, our practice in the neonatal intensive care unit, and what type of outcomes that we will have with our infants. And then, of course, I'm just going to ask a basic question. Having talked about all the, historical data, talked about some of the theories that are out there, looking at what articles have been written. What is developmental care? Well, I don't think there's one word or two words that can really help us to explain what it is. If I were to ask every one of you that are listening today, what is developmental care? We would have that many different answers, because it's individualized care. There's the old comment that a rose is not a rose is not a rose. Well, a 28-weeker is not a 28-weeker, not a 28-weeker. All of our infants are very unique, and they're very much an individual. So therefore, their care needs to be planned that way. It's a philosophy of care, because it is going to change the unit within which you work. It is going to bring about a sort of metamorphosis in the fact that we're all going to think about how we're delivering care a little bit differently. So our philosophy is going to be dramatically impacted. And it's a vehicle. It's a vehicle for creating a better environment. It is a vehicle that will allow us to integrate, and to look at the principles that are out there, and to take and see how we modify our practice, see what we can do in order to create that environment that is most appropriate with our infant. Some people will say, developmental care is light and sound. We're going to keep the sound levels down or the noise levels down, and we're going to keep the lights down too. Some people will say it's clustering of care, in the fact that we're going to take and we're going to look to see what we have to do for this infant. We're going to cluster those things that need to be done, or those interventions that we need to get done, and those that are not critical at the particular moment. If our infant seems to be stressing out, we're going to wait. It means that we're going to collaborate. It means that we're going to have an interdisciplinary approach to taking care of our infants. It also means the fact that we're going to facilitate more communication, and that we're going to facilitate that communication not only amongst the staff in the unit, but we're going to facilitate communication amongst our families, and we're going to advocate those parents be in our unit. We're going to advocate that we have positive changes for our NICU patients. We're also going to take and ask ourselves, well, why do we want developmental care? You know, if it's going to do all the things that we just talked about, then why do we want to do it? Or if the philosophy entails all of that, what is the driving force to help us or to make us want to get into developmental care? Well, number one is the fact that our infants need to be protected. As nurses, we are their first line of communication with parents and with physicians and ancillary staff. We see them every moment of the day. We're able to pick up and to look at them and to know what their likes are, what their dislikes are. So therefore, you know, we treat them as an individual, and that we listen to their needs, we watch for their cues, and we assess appropriately. We take and we say our care should be directed as to what the needs of that infant, you know, truly are. And the fact that we look at both the strengths and the weaknesses of each infant. And we look at how he responds to the environment. We take and we want to integrate our care practices from the very first day that that infant is in our unit until the day that he goes home. We want to make sure that our practices have integrated the best possible care that we could have delivered to our infant. And then, of course, we know that when we provide that environment that is conducive to growth and development, then, of course, and reduce the stress level that our infants are exposed to, that both our short-term and our long-term outcomes will be impacted. And I think this is the thing that we have to take and look at. And remember, we talked about those early intervention clinics. When we take and we discuss with our physicians, our therapists, and clinicians that are doing the early intervention clinics, if we take heed as to what they're seeing down the road when these infants come back, then we can also take and learn from this and to modify our care practices so that they're more positive and have a much more positive impact on our infants. So we know that the impact of developmental care has been very, very well documented, because we know that there has been reduction of stays in hospitals, that the days in our NICU have been less. We know that there are fewer days on a respirator or ventilator. We know that there are fewer days on oxygen. We know we're getting to bottle feeds much sooner. We know that weight gain seems to be more appropriate, and that we see less hypoxia with these infants during their hospital stay. We see much more interaction. We see the fact that our parents are relating to our infants much more positively and appropriately, and are gaining you know, a much better feel for taking care of their infants, observing their behaviors, knowing what their cues are. So when they take this infant home, they feel much more comfortable in taking this infant home. We know that we see that parent-infant attachment just blossoming, and that's exactly what we need to have happen. Because we also have to realize that many of our neglected or abused children come from our NICU environment, or come from an infant that has been hospitalized many, many times during that very first few months or first year of life, because we really have not allowed that parent and that infant to have that interaction process and to form that attachment that is so desperately needed.